Welcome, everyone, to another Residency Hot Topics. My name is Phil Forsyth. I am stepping in for Ben Keaton as the host for tonight. We are more than happy to welcome Drs. Brian R. Duncan and Dr. Catherine Anderson, who are going to be talking to us about neural tension in throwing athletes. I am going to turn it over to them to kind of handle their initial bios and let them know a little bit about their journey becoming sports physical therapists and kind of where they're at both career and professionally right now. And then we'll dive into the talk. So I'll turn it over to Dr. Duncan first. Let's hear it.
Hey, howdy, everyone. I appreciate y'all having us on. Thanks, Phil, and thanks to Ben. I know we couldn't make it tonight, but yeah, excited to be here. I've been a PT for, almost 25 years now, and down here in Houston, Texas, and I spent about a decade after graduating from A&M and then Texas Women's University. I went to work at our county hospital system, treating the uninsured and underinsured, and focused kind of on the orthopedic and manual therapy, pain science front. And then about 14 years ago, I jumped over to Methodist in Sugar Land for a bit. And then after a year there, I hopped over to Memorial Hermann to help start residency and fellowship programs in sports and orthopedics. And we've got many more now. And then transitioned more recently over the last 5 years to leading our Division I fellowship program in collaboration with University of Houston and Texas A&M. And had a close friend of mine and our first resident, Dexter Upton, now is the director of those programs. So anyway, that's kind of a little bit about me and kind of my story. I do enjoy the sports medicine front and dabble in research, and mainly enjoy investing in others and kind of seeing sports medicine grow. And I'm happy to collaborate with Catherine Anderson. So I'll kick it over to her. And as she introduces herself, I also want to give a shout out to Sean Kennedy. He's not with Memorial Hermann anymore, but he spent time at Texas Health in Fort Worth and Memorial Hermann. Now he's at Orlando Health. And so some of this comes from a presentation we gave at the AOMT conference in 2023 about neural tension and just assessing throwers. And Catherine has stepped in and tweaked it and added some cool biomechanics things. And so hopefully that's a fun thing for the listeners. Catherine, over to you.
Yeah, so my name is Catherine Anderson. I am technically pediatrics trained. So I did my pediatric sports residency about 6 or 7 years ago now. And then I came over to Memorial Hermann about 5 years ago with an interest in upper extremity. We had a new physician coming on, and there was a lot of cool opportunities that I was going to be able to take from an upper extremity standpoint with Memorial Hermann. And so I've been here for the last 5 years. And my role is I am the upper extremity program coordinator with a lot of ties into our sports and orthopedic residency and also into our upper extremity athlete fellowship. And so my day looks like I'm pretty much treating shoulder, elbow all day, every day. And I spend a lot of time teaching in that area as well, because I want others to kind of have that understanding and not be afraid of the shoulder and elbow, the way a lot of new grads tend to shy away from. But for the most part, my day is high school and college baseball players. So it's a lot of fun from that standpoint. Yeah. So we're going to talk about neural tension in our throwers. Some of our objectives for today, talking about, upregulated neurovascular system versus thoracic outlets and biomechanical deviations, kind of how we're screening that out, and then what we're doing about that in some of our athletes. So this image helps to kind of show the kinetic chain of a pitching sequence. And so it's going to show that emphasis from the drive leg through the stride leg, connecting through how kind of that transfer of energy starting from the ankle and knee through the hip and trunk and ultimately through the shoulder and elbow. The throwing athlete has very little time to successfully coordinate this task, and failure to do so consecutively and the way we kind of want it to go can end up in a lot of deviations. And one of the big things we're seeing with that is an increase in neural tensions with some of these deviations. And so when we look at throwing biomechanics, we can't talk about neurotension without talking about some of the biomechanics of throwing, right? And some of those deviations that may cause us to have significant increase in stress for the shoulder, the elbow, and also the nervous system. And so one of that is going to be stride foot contact. And so if we have an open lead foot, what that's going to do is it's going to change our pelvic rotation, which is going to change how we're transferring our energy through the throw. This in turn is going to increase that force through the anterior shoulder and also the medial elbow. As we are increasing those forces, we are also putting more stress through the nervous system. And so we need to be concerned from that standpoint. Also in stride foot contact, we're going to see increased shoulder abduction angles. And that increased abduction angle is going to increase that elbow valgus stress. When we are seeing that higher abduction angle when they're at ball release or stride foot contact, what we're going to see is we're going to get some of that lateral trunk lean. As they're leaning away, we're going to start to see that traction through the brachial plexus, increasing that tension across the nervous system. And then what we're seeing is with every about 10 degrees increase of shoulder external rotation at ball release, there's going to be about a 2.3% increase in those forces across the shoulder. With this, we're also going to see 5.9% of increased shoulder distraction forces. We're distracting not only the shoulder joint, but the elbow, and we're also putting traction through that entire brachial plexus as we are throwing. And so while we're talking about, that neural compression, that neural traction, we also have to talk about what are some of these areas where we may have more of that compression. And so some of the big ones are going to be our inner scalene triangle, in that area between the anterior scalene, middle scalene, and first rib. Our costocovicular space, so that area between the first rib, subclavius muscle, anterior scalene, and also the clavicle. And then also that subcoracoid space where we're looking between that pec minor muscle, the second through the fourth ribs, and the coracoid. And so these are some of those areas when we're starting to look at from an assessment standpoint that we need to kind of have on our radar of areas that we might be concerned for some of that compression. And so as we start talking about some of those anatomic abnormalities, while we're going to have some compression in some of these areas, there's some soft tissue and bony anatomy that can help kind of increase some of that as well. And so from a soft tissue standpoint, we're looking at the scalene minimus, which is found in about 30% to 15% of TOS patients. And so not everyone is going to present this way, but it's something to have on our radar for some of those that are going to be more in that true thoracic outlet type of scenario. We're also looking at potentially morphological changes to the pec and pec minor. Are we having increased tightness that is going to provide some of that pressure through our throw? And then bony anatomy. We're not changing the bony anatomy, but we need to be aware of it. So do we have the presence of a cervical rib? Do we have a prominent C7 transverse process that may cause some compression? And is there anything kind of scary, crazy, wonky? Do we have a tumor, anything like that that is going to cause some of that changes into that compression? And so even though this is more a neural tension talk today, we still need to be aware of thoracic outlet syndrome. And far and away, the most common that we are going to see is going to be that neurogenic subtype, but also being aware that we have vascular and arterial compression as well. And so in that venous, it's going to be associated with that strenuous work using your arm, that overhead, that compression. Whereas in our arterial, most common issues are going to be that scalene triangle, and most of the time they're going to have that cervical first rib. But again, far and away, we're talking about that neurogenic type of symptoms. And while the neurogenic isn't necessarily going to change how we're treating it, we do need to be aware of the difference between a true thoracic outlet and more of that disputed neurogenic thoracic outlet. And that's kind of the area that we're going to see in our baseball players. But that true compression, that true thoracic outlet is going to be the physical signs and symptoms of nerve compression. So we're seeing visible hand weakness. We're seeing that muscle wasting. We are seeing very definitive changes on those EMG testings, more so than just slight slowing. There is significant compression happening. These are the ones that, hey, if my car is parked on my water hose and I pull off, I'm not having any of that change in that rebound. That disputed, those are going to be the ones that, hey, we are tensioning, we have that intermittent compression, but we are not consistently having constant compression. These ones are often going to be worse in those overhead motions. So think our overhead athletes, our throwers, they are going to have those symptoms in those throwing positions. They don't necessarily have those classic objective findings. These are some that they may have gotten an EMG, and if it's not someone that is looking at EMGs in this population significantly, they may say, hey, this was within normal limits. However, when we start comparing their throwing side to their non-throwing side, we are seeing slowing in the involved limb compared to our uninvolved limb, even if it's within our normal ranges. And so signs, symptoms, talking about just different types, there is going to be some overlap, but again, that neurogenic is going to present more as just that pain, neck, trap, shoulder pain, and maybe that tightness more so than they're saying, hey, it's numb, tingly, but they may have that numbness. They may say that paresthesia and muscle weakness. Venous, we're going to see that arm swelling. We are going to see visible changes in the arm discoloration. We may see that vein distension, chest distension, depending on where it is. And these are going to be more your classic, I feel heavy patients. Arterial, it's going to be a lot more related to that ischemia. So they are going to have pain, they're going to have paresthesia, and they're going to have those claudication type of symptoms. They're going to say, hey, my hand is cold, or you're going to see that change in their hand from a coloring sensation. But in our overhead athletes, they're not always coming in with those classic cut and dry, this is what I'm feeling. And so what that's going to look like for them is they're not going to come in and they're saying my arm is heavy. They're not going to come in and say my hand is cold, but they're saying, hey, I'm getting fatigued easily. I don't have the endurance. I used to be able to throw this many on the mound, and now I've gone down to this as my pitch count. They're going to say, hey, my velo has gone down. And that's going to be oftentimes one of the first things they're noticing is their velo is not there. If you start asking them how their command is or can they feel the seams, they're going to start thinking like, hey, maybe I can't feel the ball quite as well. I don't have that control into where I'm going. And at the end of an outing, they may say, hey, my arm goes dead. They're not going to feel it when they're playing quite as much as that. They're coming off the mound and they're like, yes, no, my arm feels dead now. And so when we look at clinically diagnosing TOS, it's not necessarily the most sensitive and specific. There's not a true cut and dry, these are the best tests to use. We more so want to look at it as a cluster together. Theoretically, there's tests that are going to compromise the vascular system specifically, such as the ADSENS test, Halsted, Wrights. Others, like the RUS and the Cyrex, they're more likely to reproduce that neurogenic pain or paresthesia. But together, they're best used in kind of a cluster across the board to say, hey, if we start looking at a bunch of them together to start making that diagnosis of a TOS or disputed TOS. A lot of times these are going to come down to we've ruled out a lot of things and we're starting to get a lot of positives in these type of testing. And this is a test, this fold AVAIR overhead activity test is a test that one of our physicians who is seeing this, our throwers a lot and seeing this type of diagnosis frequently is using. And so what we're doing here is we're going to place the patient in the position of their max cocking or their layback position with their end range glenohumeral external rotation and horizontal abduction with 90 degrees of elbow flexion and contralateral cervical side bend. We're going to have the patient open and close their fist for 30 seconds, and they're going to let us know when they're having those symptoms. And we're going to ask them at about 15 seconds and again at 30 seconds. This isn't necessarily a validated test, but it is something we're finding when we're putting these patients into sport-specific positioning that we're starting to see some of those changes to be able to couple that with our evaluation of peripheral nerves and other kind of neural testing to say, hey, this is starting to look like we're getting that kind of, disputed neurogenic thoracic outlet, or we're starting to say we're having an upregulated neurovascular symptom. And so we can kind of grade it on various, minimal to severe based on when those symptoms are occurring. And when we're starting to look more specifically at just, are you missing neural tension? And do we have an upregulated neurovascular system? We can look at more than just, is it a positive upper limb tension test or is it a negative upper limb tension test? We want to know what their sensation is. How much can they tolerate? How big of a stretch is it? And start to quantify kind of an overall symptom of it. We can look at positioning. how extended or flexed is the elbow in different situations? How quickly does it go on? And how long after we take that tension off do they continue to have some of that pain? I gave these two pictures. These are, your classic upper limb tension, but they may not always get that reproduction of symptoms in our overhead athletes and our baseball players. And so this is an example. Yeah, you can play it. And so this is how we're going to go through kind of some of our neurotension testing. And in these athletes, we're looking mostly at median nerve and ulnar nerve tension. And so this is an example of how in some of our overhead athletes, we're going to look at that median nerve tension. And with thoracic outlet or this upregulated neurovascular system, and especially in our overhead athletes and our baseball players, they tend to sit in that kind of shoulder droop position, scapular down already. And so we want to be careful, and we don't want to over depress, because if we are over depressing, we are going to over traction the nerve, and we may get more symptoms than if we're just kind of preventing that humeral head migration in some of these testing. We can change this up by saying, hey, how extended are your elbow? Or we can start them with a full elbow extension and bring them up into higher levels of AB adduction. The goal in some of these athletes is that we are getting them to 90 degrees AB adduction, able to get that full extension, because that is the position that they're going to need to get into for throwing. And then with our ulnar nerve, we can take them through all the way in that kind of classic ulnar nerve tension test. But if it's someone that is highly irritable, or you maybe have a little bit of ulnar nerve sensitivity or potentially subluxation, that picture on the left might not be our best option, because they may get some of that kind of snapping syndrome, and it may kind of falsely irritate the nerve before we're actually getting that tension. And so we can keep them in that elbow extended position where we're not compromising that medial elbow, and then bring that wrist back into extension to do some of our tensioning for these athletes. And with all of that testing, we want to make sure we're looking at the whole picture. As clinicians, we're more than just, hey, let me do this one test and say, here's your diagnosis. And so we want to look at the full picture. What's their range of motion? What is their strength? And then overall, what are their symptoms? How well can they tolerate some of these positions? But also, how long are they symptomatic after we take them out of some of these positions?
All right, now we're going to switch over to a little bit more we're going to build on that clinical exam and talk about targeted interventions to kind of downregulate the nervous system and reduce symptomology, and kind of just thinking through our treatment methods and how do we want to order those. And so kind of working around the clock, but starting over here at manual. Let's see if I can do it. Starting over here at manual therapy and moving around the clock towards nerve mobilizations, exercise, and then some of the influencers of the overall setting. And so, how do we handle the lions and tigers and bears? And so I like to start with looking at posture and how does the shoulder sit? And understanding the sport activity and demands, which I'm sure everybody does. And then I do light thrust joint manipulation to the thoracic spine, occasionally the cervical spine. I'm trained in it. I use it less now than I used to, but and then nerve mobilizations, and then sliders and gliders and tensioners, and then regional interdependence. And that term's kind of old now, but how do we work from the kinetic chain, and how do we work from the ground up, since that's where we're deriving our power from? And then what kind of influencers? We know baseball players and some of our other athletes can be peculiar beings, and they like things a certain way, and then we know many of our college folks are highly caffeinated and underslept. And so what might that be doing to the nervous system? So, all right, so manual therapy, right? We've got what we're all doing now. We're slumped over a computer or a phone looking at things, or we may have people who are in dance or gymnastics, and they may have overly depressed clavicles. And so you may want to definitely look at the clavicular angle and see if it has a natural upward slope, or they had, unilaterally dominant athlete like a thrower, and where one side's depressed and the other side has a natural upward slope. The other thing is to consider their mechanics and what are they doing with their neck as their arm is coming through. And we didn't dive into it, but we may go back and look at some of the pictures that Catherine started us with to talk through some of that biomechanics. But as kids are young and trying to throw harder and harder, they're going to lead with their neck and drag their arm through the zone. And as that arm drops and tries to externally rotate, it's going to hyperabduct. And that's going to be a great neural tension position, and they're going to do that repeatedly. And then we've got the thoracic spine, and we've got the sympathetic trunk and ganglia. So there's a way to influence the nervous system through thoracic manipulation. And the bigger the kyphosis, the less extension range of motion they're going to have, or what we would say here for baseball is the maximum flexion. So the more you're slumped over, right, the less high that arm's going to go. And then the harder it is to get that layback that you're looking for. And we know that people with subacromial impingement syndrome can benefit from thoracic spine manual therapy, especially in the older population. So if you're seeing older throwers, probably not, but if you are, but I would say I'm seeing a kid with little leaguer shoulder right now, and his thoracic spine is pretty stiff, and he's got a forward flex thoracic spine that looks like he's 40. So anyway, and then with this, an improvement in posture, particularly an improvement in a thoracic kyphosis, and early detection of silent elbow extension deficits can prevent, medial elbow injuries in young baseball players. So keep that in mind. And so this is kind of what I was saying, the ability of the shoulder to get the scapula to get vertical and get the socket vertical is contingent on the ability of the thoracic spine to extend, and then that shoulder blade to tip back. And we also want to consider the cervicothoracic junction and its relationship with the painful upper extremity. Sometimes you would do well to screen the cervical spine, and all your upper extremity athletes looking for cervical mobility deficits or CT junction deficits. Less neck mobility is increased during the preseason, had an increased risk of time loss, injuries, and shoulder and elbow disability during the season. And so be sure to be assessing that with your athletes. And then again, kyphosis is not a good thing with regards to medial elbow. So again, if you can't get your arm easily up, your elbow is going to drop, and then you're not going to have much external rotation. You're going to put a lot of demand on that medial elbow, and you're going to hyperabduct at the shoulder to make up for a lack of external rotation. Devaney, when I was presenting this at AOMP with Sean, she was in the audience. So we're presenting, and then she's seeing her research from her PhD get mentioned. But this is not new to anybody in manual therapy. Just flex the chin all the way to their, towards the sternum, and then hold that and rotate and assess side to side. And she found in college baseball pitchers that with less neck mobility during the preseason had the increased risk of time loss and shoulder and elbow disability. So checking shoulder rotation, looking for compensatory motions that may decrease the space for nerve roots in the intervertebral foramen. So another thing I like to say is, especially with people who have a pretty thick build and maybe heavier arms or a very strong chest and bench, that's not me, but they have the rounded shoulders, and then they put their head up, and then their chain that they're wearing disappears in their neck crease, and you can't really find it. You can't see where it clasps together. Like, imagine how extended they're sitting at the lower cervical spine. So imagine what that is potentially doing is kind of a double crush to their nervous system before they even get to the brachial plexus. So assess the neck. There's a few different ways. I love thoracic manipulation. I like supine. You can also do it prone. You've got, everybody likes a foam roller. You can do cervicothoracic mobility, the bottom left. There's some different cervical manipulations and thoracic mobility. So interventions, manual therapy. This one at the far right, let's see if I can make my laser pointer. This guy here, I don't know, can y'all see that, Phil and Catherine? It's my laser pointer coming up. So a lot of folks don't like cervical manipulation, and I think, there's ways to avoid end range rotation and things like that. And so in this case, I'm compressing, her head between my forearm and my chest, and I'm avoiding curling my fingers around her chin. My left hand is underneath the occiput like this, and I'm just moving my whole body. So to execute on this manipulation, I just literally look over my right shoulder and then shift my hips and move, and it's just a straight distraction manip. So we're avoiding kind of the rotatory end range movements that you often feel, and you can often manip, all the way down into the cervicothoracic junction with that. And then with soft tissue, be wary, like where the thumb is here. That is right where all the nerves are coming out through the scalenes. And so I remember when I was young thinking, man, I am moving the heck out of her, the rib. And I was really just on the top side of the rib cage, right where those nerves are coming out. And so move around back a little bit and where you can really mow the ribs without jamming your fingers and smashing all those irritated nerves right over the ribs where they come out. Let's see here. Let me get rid of my laser pointer. Go. All right. All right. Position of the scapula. So we talked about posture and thoracic spine. This guy's thoracic spine is good. Maybe he has a slight scoliosis. But what you can see is we've got a tipped, downwardly rotated scapular position, right? So that's trying to dump the shoulder out of socket, right? So that rotator cuff has more work to do just to keep the head centered in the socket. And the depressed downwardly position, so you're going to see the level clavicle on the front. Some of this is normal. We'd expect that in a unilaterally dominant athlete. And then the anterior tipping or the winging of that inferior medial border. And so these are all things, right, we're looking for. And some of this is adaptive, but when they come in with shoulder pain, we're like, I don't know that we're going to continue to tolerate this. And then we can see what some light dumbbells. So for these, you can use a metronome and do 60 hertz, or you can just do it like this and just see how they look. In flexion, you can bring it out to scaption as well, but you're going to see more in the flexion position. And you can see a scapula not staying, tight to the thorax. So like there's not good reliability for subtle, mild, severe is probably the best we can do. But it is something that I highly suggest you assess and look at either with dumbbells. I think you can also just have them reach out and you can be behind them and watch what happens when you push down on their arms. But it's nice to give them some dumbbells and let them go to work. And so you got your scapular depressors, right? The lat and the pec tend to be pretty strong muscles on more mature throwers. You got the downward rotators, including the levator and rhomboids, along with the lat, and then anterior tilt. Pec minor tends to be very tight, and then posterior shoulder tightness. And so probably good to mention that the posterior capsule is not huge, and and thick. And so we're not really stretching the posterior capsule, but that tightness comes from, a lot of eccentric load. Just like our hamstrings get tight if we do a bunch of RDLs, that heavy eccentric load, the backside of the shoulder from throwing and the ball release and slowing down the arm is going to make the backside of the shoulder tight. I like to assess it, and I'll maybe have Catherine chime in, but I do like to assess it with holding the scapula down and assessing cross-body adduction and making sure I'm not letting the arm externally rotate and seeing how far they're coming across the body. Catherine, anything you'd like to say on that front?
Yeah, I'm definitely looking at that on every patient that is coming through that's a thrower to see kind of what that is looking like and how tight they are there.
Yeah. And oftentimes you'll find that they're not getting close to having their elbow get vertical. So I just try and see if they can get their elbow vertical and have a little tolerance to this, which looks remarkably like an impingement test, right? But if you're coming across, you may have to give them some external rotation initially to even be able to start to stretch that shoulder. But as you work on it and you stabilize the scapula, you're going to want to get here, and then maybe even as they loosen up. And so that'll be part of, your arm care program if you're in a spot where you're caring for throwing athletes on a daily basis. All right, so we've talked about posture, manual therapy, those kind of things, nerve mobilization, sliders and tensioners. So there's a lot of information here, but gliders or sliders tend to provide greater nerve excursion, but less tension, seems less aggressive and more appropriate for highly irritable conditions. Makes sense. Consider for more acute, highly irritable. And the gliding likely occurs between the mobilized joints, but and then the tensioners, right? They're great for assessment, right? And they're great for desensitizing a nervous system that is on the calmer side. So I use gliders early and then tensioners later. There's also some evidence that you can do, if I'm a right-handed dominant, that's where my neural tension is. I might do tensioners on the left because there's some evidence that can help calm things down on the right. And on the right, because you're irritable, I might use more gliders. So something to consider. There's also a role, and I'll show a couple pictures for assessing the lower body nervous system. So like a slump test or having them put both their feet sit long sitting and then do a seated kind of flexion test and see if that bothers their nervous system. And that bothers their nervous system, then it's quite ramped up. And then the dosage from the literature, a series of 4x10 with a rhythm of 6 seconds per cycle, 1 minute between each series is what Coptier's presented. Now, this is not recent literature, but comes from a pretty reliable source. And so this is something Catherine and then Sean, I mentioned, have put together and utilized quite frequently. So we've got a median nerve glide, an ulnar nerve glide, and you'll notice that, right, that ulnar nerve glide is not here. And that's because oftentimes this, like Catherine said, may provoke an ulnar nerve that subluxes, but oftentimes is not where your throwers are going to have any symptoms at all. And then I'm showing Sam, who's he's a PT at the University of Nebraska now, but he's working with a throwing athlete, a kid who had some diffuse neural tension signs. He ended up in our clinic, and all the normal stuff he was describing, like disputed neurogenic thoracic outlet, but all the normal tests were negative. But then we put him in a pec stretch position and then started assessing his nervous system, and it lit him up and it reproduced his symptoms. So what Catherine was saying earlier with working on neural tension or checking the vascular system in functional positions, definitely believe that. And we definitely see more median than probably ulnar symptoms, but I would check both in this in this sideline position as well, if you're finding that they're negative on your basic test. The other thing that was provocative with this guy, and this actually helped desensitize his nervous system, is doing almost a glider. Now, his legs weren't moving, but he would basically just flex his neck and then come back out. That would bring on some diffuse posterior shoulder pain and then relieve it, and bring it on and relieve it. He had no neck symptoms, but this is something else to check in your stubborn cases. All right, so we talked about how to downregulate with manual therapy and nerve glides or tensioners as they get better. Exercises. This is pretty important, I would say, is that on these throwers, you're assessing true glenohumeral abduction. So a lot of times our surgeons will just rest their arm on the patient's upper trap from behind, grab their elbow, and just see if you can easily get that elbow up to 120. And you'll often find that in people with ramped up neural tension that they actually don't have the shoulder abduction you would expect. And then we talked quite a bit already on the crossbody internal rotation. So assessing that. This quadrant stretch is kind of cool. You basically stabilize the shoulder with your left hand, and then you're pulling the elbow up into abduction, and then you're using your thumb to play around with how much internal rotation it is, and you tighten it up, and then you try to bring the elbow, slide it back towards your body into abduction. So that can be a good, what we call quadrant stretch. And then a lot of people know how to stretch in the shoulder flexion or stabilize that that scapula when you're trying to get the arm overhead. All right, pec major. So this can be big. I like the sideline position I showed earlier because you can both stretch the pec. I can also take my hand and put it over the anterior shoulder in the coracoid process, and then push the scapula back in a sideline position, and get a good stretch without just putting a ton of pressure on the anterior shoulder. The other thing to think through is these sites, these zones of compression for the bicipital, along the bicipital groove, along head of the bicep. So zone one, right? We've got your articular margin. Between the articular margin and the distal margin of the subscap. And then in zones two, they call no man's land. It's from that distal margin of the subscap to the proximal margin of the pec major. And in here, you generally can't arthroscopically get in from the shoulder or subpectoral. So that can be clinically and diagnostically challenging. And so, yeah, anything you'd like to add to that, Catherine?
Just keeping in mind with some of those zones when we talk about stretching the pec, and if we're looking at just like a pure pec release, being aware of kind of how much maybe pinpoint pressure you're doing versus staying like a little bit more broad over some of these sources, knowing, you know, how much is actually running through in that small area. And we don't want to continue to close down on a space that's already having vascular and neurovascular compression.
Yeah. Yeah, I appreciate that. The other thing I would say is particularly if you're seeing throwers that, like I said, are big benchers, so they're 225, maybe 315, those kind of guys, you might consider, so let me come back here. I'll do some of these sideline, like I said, stretches, but I will also stretch them into extension where I'm literally putting anterior pressure broadly, like Catherine mentioned, and then I'm stretching their arm straight down towards the floor, and then I'm working my way out into abduction. And you'd be surprised how tight their pecs are down there, which means every time they go to bench, their shoulder is going to anteriorly tip, or anytime they try to do a dip, or a push-up, you're going to see some of that dipping, which is going to put pressure on there. When that shoulder tips, then you're going to get strain on that bicipital tendon in the groove when that humeral head translates anteriorly. So something to keep in mind. Pec major, so soft tissue, release, being able to, get the arm in a functional position and then playing around with neural tension. So with rotation and side bending of the head. Lat mobility, Catherine and I were talking about this. We typically do this stretch where you'll bring your elbows almost as close as you can together while you're putting them on a plinth or on a box. And then I like to walk my hands out on the PVC pipe or stick. And then I'm going to back away my rolling chair or stool, or lean back if you're on all fours. But I like to get those elbows tight together and then walk the hands apart. And then first rib mobility, this is a good way to train your athletes. And then thoracic mobility and hip mobility is a must. And I think all of you know that. I like doing this in an RDL position. So you'd stand on that right leg. The left leg would slide up and back along the wall, and then you would do this same opener. And it is great for hamstring flexibility and thoracic mobility. ER walkouts, so you can walk it out, then you can pulse while you're there and get in a bunch of reps. You can progress to single leg throwing. This squat to W is great. It looks easy. The reaching out and then standing up and keeping the elbows low also gets a lot of thoracic extension. And so while it does work your cuff muscles, it also has a postural component. And then just thinking through, how are we going like from legs to trunk and back to shoulder to elbow to wrist? And just thinking, are we addressing all of these things? And then down regulation of the nervous system. So having a good therapeutic alliance obviously is good. Breathing, I don't get overly into breathing, but sleeping is important and caffeine is important. Or caffeine is maybe important because it's overdone. And so it's just consider, I'm not saying it's going to fix your neurogenic thoracic outlet or disputed neurogenic thoracic outlet. What we do know is that it works as a stimulant for endurance and strength power sports, but we also know that too much caffeine causes anxiety, shortness of breath, elevated heart rate, GI upset, sleep issues. And if we think about what those sleep issues, that anxiety, and the caffeine are doing to mechanosensitivity, it's probably not in our favor. So I would definitely ask about that. It's kind of fun. These are kind of caffeine for athletic performance. So this is something our sports dietitians put together that I just cropped for this. So prognostic factors, who does well, who likely does not do well, how long do you treat and manage it, when you refer, and who do you refer to? And so maybe we'll stop here and take some questions, and maybe we'll see from the audience, who do y'all think, well, how often do you feel like you see this in your throwers, and who do you think maybe does well? And you can drop it in the chat. That's easier. Oh, and then while people are thinking, the 60 hertz specifically to test the scapular dyskinesis. Yeah, that's, I may be able to post or share some with Ben, but it's in our return to play module, but looking at 5% of body weight, 60 hertz. And if I remember right today, you're looking at 20 plus reps to be normal. Catherine, I don't know if you know that off the top of your head.
Yeah.
Does that sound right?
Yeah, and a lot of it is also when you're looking at some of these athletes and you think how many times they're throwing and how strong they are at baseline. If they're in an unweighted position and you're just looking through range of motion, you may not see some of those changes or that dyskinesia or the winging or, however we want to label it. But as we start adding that resistance, then we're starting to see and we can track over time what's actually happening under fatigue. Because if all you're looking at in your athletes is 1 to 2 reps unweighted, that's not kind of going to be that carryover symptoms that they're going to have into the game. And so it'll help kind of make that carryover into clinic a little bit more specific.
Yeah, it's a great point. Another thing on this 60 hertz, it's really essentially 30 reps per minute. So down on one beat, up on the next beat, down, up. And so also used for the lower extremity folks, similar concept to the Vail Sport Core test. So kind of similar concept of using the external cue at 60 hertz. You can also do it for a Y maneuver, so at about 120, and you're using, I think it's 3% of body weight. And again, you're looking for 20 to 30 reps. What I will say is you don't get a rep if you can't get it to even with your ear. So and what I like to do, and Catherine can probably speak more, is I actually on a plinth, so I'll have them coming up front, I'll have them put a towel roll to keep their forehead down, because if their forehead's off the edge of the mat, it does a couple things. It allows them to lift up and kind of artificially extend the thoracic spine. And so they'll get a better scapular tipping, but they're cheating to get it, and they won't have that same thing when they're on their feet. So I have towel roll on their forehead so their head stays down. And then you really get a good idea of like, can they get their arms essentially off the mat? And you'll be surprised, especially with your younger throwers, they won't even be able to lift their arm off the mat. And if you do it on the floor, it's even harder because you're already in an in-range position. So anyway, something to check out. So anyway, maybe Catherine, back to you. Prognostically, who do you feel like does well in this case?
I think the ones that do well are the ones that I can make changes on in that first visit. And that's not to say that I'm, taking all of their pain away or things like that. But if I'm doing a quick peripheral nerve screen and they can't resist me at all, they can't do an okay, they can't hold their abduction. But I can do some neurotension and I can release them. And now all of a sudden they're starting to get some of that activation back. Those are ones that I'm saying, hey, we have some good chances because you still aren't completely compressed. You have the ability to get some of that activation. But in a lot of times I'm treating these guys for up to a year before I'm really saying, hey, we need to go talk to one of our other physicians, or I need you to get another opinion, things like that. Because a lot of times we're looking at these throwers and they're, high school, college kids at this point, and how many pitches have they thrown in their career? We have pitch counts on these kids, but we're not counting what their bullpen is. We're not counting what all their warm-ups are. And when you start looking at the overall load across, lifespans of what they're throwing, these aren't patients that you can say, hey, I'm going to wave my magic wand and you're going to be back and everything is going to be great in a week from now. And it can take up to that kind of year timeline to say, hey, we're making those full changes and we're getting you all the way back. And that's not to say you're seeing them in clinic twice a week for all of that, but as they're starting to progress back into throw, I may be seeing them, once every couple of weeks and checking in and seeing what they look like.
And then maybe question, what would you say about EDS and trying to map that out as far as how they do and things like that? I would say I would just say these folks are challenging to treat. Typically challenging twofold. One, I feel like they're challenging from a pain science approach, and they're challenging from uh, how much volume and load will their body handle as they move up playing levels, because it may not, their skill and ability may be higher than what their body can actually tolerate and their desire to play at a higher level. And so there may be a good bit of load management there.
I think there are also ones that are hard to manage on how do we push the limits of your neurovascular system without overdoing it and having to be careful from that standpoint. And in our tensioners, and maybe we're sitting a little bit more into gliders in these scenarios and keeping them in a little bit more of a happier range as opposed to taking you out into that full tension.
And I think these folks probably need non-irritating strengthening more than most, because the tighter you can and stiffer you can make these folks, the better they feel. And the more time you spend it in range, especially unchecked, the more irritable they're going to be. And you said you managed people for a while, and then when do you refer? And then who do you refer to? I think this can be interesting.
I'm a little biased because I see a very high caseload of people coming to me who are already, diagnosed as TOS, neurovascular compression, and upregulated nervous system. And that's because I primarily am treating from Dr. Conway, and he's a physician who's looking at it and looking at it regularly. And we have another physician within Houston outside of our system who isn't necessarily looking at it, but is starting to understand that there is something to be said about neurotension. And I have a kid who was managed for posterior labral tear for 6-9 months, despite the fact of imaging kept coming back as normal, and MRI was saying no labral tear. But with the symptoms and the posterior pinching that he was reporting, they were treating it in that regard. And so he had gone through about 6-9 months of rehab. And this physician had ultimately, called us and said, "Hey, I know you're looking at this, and I don't fully understand what you're doing, but I know you're seeing changes from that regard." And I've been managing this kid now for about 6 months, and it's 2 steps forward, 1 step back. And he had his first pain-free mound in December, and that was the first pain-free mound he'd had in about 1.5 years. And now he's, fingers crossed, through a full bullpen tonight. I haven't heard anything bad from that standpoint. So, fingers crossed that everything went well there. But there's kids that, he's had successful bullpens, and then we've had to step him back and re-ramp him back up. And it's been that little bit of a slower path to get them there. And that tends to be what we're seeing in these kids. And I'm starting to talk to him, and he couldn't feel the seams on the ball. He couldn't have grip. And you're like, well, how long has this been going on? And it had been going on long enough that he didn't even realize that he wasn't able to feel the ball once he started being able to feel the ball again. And so when you're starting to see like that, it's okay to be treating these guys for a lot longer.
Mm-hmm. Okay, and then maybe let's do this. All right, so here's our contact. Like Catherine said, we like to dabble in residencies and fellowships, and we've got a Division I fellowship. We've got a spine and manual therapy fellowship. So any sports nerds that like the spine and want to train with surgeons, but also with manual therapists and do it across the lifespan, use bone saws, do that kind of thing. We've got a really killer. It's the only one in the country that combines, you get your manual therapy fellowship, and it's a spine fellowship as part of ABPTRFE. And then we've got an upper extremity athlete fellowship between us, the University of Houston, and the Detroit Tigers. So, but that said, I was gonna drop in a couple things. Come back to that, but I think, let's see, handheld dynamometry testing. Here we go. So here is the, come on. Let's see, I don't know. All right. So you've got a standing cable press where you can do an endurance test with 20% of body weight, standing scaption at 5, and then the prone Y at 3. And I'll tell you, it gets a lot easier when you do a full range of motion off the side. But if you, again, put the towel roll and put them in the middle of the mat and they can't go all the way down and they have to come up, things get a lot harder. So, and then here's a look at their repetitions. Yeah. And then maybe the other thing Catherine and I have learned a lot more about, and we don't really have time to dive into it, but that our bones adjust to what we do athletically as we go through puberty. And let me see, let me try one more time to play this. Let me try this. Sorry, I'm trying to flop between screens to get the right thing to show. We stop share and then I'm going to reshare. All right. All right. Let's do this. Do you want to just mention, Catherine, humeral retrotorsion real quick?
So my 30
No,
second
not how to
elevator
measure.
pitch to
Yeah.
parents when we're
Yes.
talking about humeral retrotorsion, because I'm measuring it and they're like, what the heck are you doing to my child right now? When we're born, we have a ton of retrotorsion in our shoulders. And if you ever see a baby sleep, their arms are all the way back and they're up overhead. As we kind of grow into society, as we develop, and as we come down into more of this kind of anterior position, I need to sit at my computer, I'm hunched over my computer games and all of that, we end up losing that retrotorsion and we come forward and we come down. However, we are talking about overhead athletes and we're talking about throwers, and we are saying, hey, you need to get into max layback, you need to get into max layback, you need to get into max layback. And as you are doing that, you are actually you're preventing that normal torsion coming down and you are staying into a retrotorted position. And so what we're saying is when we're talking about GERD internal rotation deficit versus GERD external rotation deficit, how your bone twists and how much retrotorsion you have may mean that even though I'm seeing 10 degrees of internal rotation, that you don't actually have an internal rotation deficit, because your bony anatomy has you going more into external rotation than your bony anatomy will allow you to go to into internal rotation. And that's what I tell parents on it multiple times a day.
Yeah, and then what I'll say is most people with a sore arm or neural tension lose external rotation. And so again, what will happen is their arm hurts, they drop their slot, and then they're going to hyperabduct because you can't externally rotate very well with your arm, your elbow below, but with your elbow above, like I can lay back a mile. The further that comes down, now you can't lay back as much. So you're going to hyperabduct, and then you're going to pull through and you're going to literally drag your arm through the zone. So you're literally going to put even more tension on things. And so knowing about humeral retrotorsion, knowing that people actually lose external rotation and then they lose crossbody adduction, they really don't lose internal rotation, and they'll even lose true glenohumeral abduction. So I think if you're taking some things away, we talked about how to treat the nervous system, but also make sure as that shoulder calms down, like a knee when it's not swollen, when your quad's functioning and things like that. When the shoulder's happy, you'll have a much better layback. And so a lot of times you can stretch and do all these things, but if you're doing the right things, a lot of times that layback will happen a lot better as the shoulder gets happy. So, well, cool. I know we're over time. I know we introduced a couple things a little late in the game, but I thought there were good questions and good transitions. Phil, anything from the group that hung in there? I know it's 9 on the Eastern Seaboard, so.
No, I think so far all the questions were answered. Anyone have any last minute questions before we wrap it up?
Adria, you're welcome. Appreciate you hanging in there.
Thank you guys for coming.
Yeah. Phil, thanks so much. Tell Ben hello. And Catherine, always fun hanging out.
Absolutely, guys. It was a pleasure.
All right. Y'all take care.
Have a good day.
Yeah.